Make sure you mark that on his evaluation.
We were taking bets on whether or not you would remember.
Long year.
Christina was betting against you.
I was saying tomorrow. You're gonna check your equipment first.
So today's the last day of the tickets. Tomorrow's last day.
Is this working?
Well, the husband's on other doors.
What door? This way?
Okay, thanks.
Hello, everybody.
Sit.
Everybody's ready?
Next slide.
I don't know, maybe a few of you here. So my name is Alfred Aung. I'm one of the Geriatrics fellow doing the one-year fellowship. I was trained as an internist for 5 years, and I was in practice for 5 years before. So we'll start with this way.
I'm Maria Wellish. I'm from Morningside Ministry in Education.
All right, very good.
You know, Rio's Morningside Ministry. I never heard of it.
Can't see her.
All right.
I'm going on their rehab center.
Rehab, okay. I know Jessica.
Mark with the South Texas Geriatric Education Center.
All right. Christina, Linda, Debbie,
Randy
Randy,
Harris.
Rhea, and
I'm a dentist at the Garage.
yes, I forgot your name, or
Chico Ye.
Chico. Ye, right?
Yes.
Last name Y-E?
YH.
Y-E-H, okay. Very nice. So today is my first morbidity and mortality presentation. This is the only one that I could think of and dig up that I was involved in. So this, I don't know, are we allowed to say where it happened, or as long as it does not have personal information? So it was during the ACE unit rotation at the Santa Rosa. I just wanted to find out if I can say it before I say it, right?
What the rest of us need.
So, a brief overview. The reason I picked this is because this is what we're going to be seeing for most of our career. Is an elderly person with very poor family support and who present with a very complex diseases. So somebody whose family doesn't come to the hospital and give collateral information and does not accurately reflect what the patient is, or interpret for us what the patient is feeling, and whether or not what he's saying and doing is whether it's normal or is something that is out of the ordinary. So without those information, it makes it a very complicated case in particular. And then this one also is a case where something obvious makes another complication that is underlying, very easy to miss. And then of course there's dementia that's complicated anything else. And atypical presentation or something that's could be easily missed that almost cause morbidity that is permanent. So objectives. So what I want you to take away from today is to at least describe what are the ways that Coumadin therapy can go wrong, and also to realize that poor history can hide a lot of diseases and other complications underneath all the glaring evidence that's staring in your face. So, and also to recognize presentation of I'm giving away things here, compartment syndrome, and how you can recognize those in some situations. And also to realize, lastly, that we can always manage pain very aggressively, but also that can be hiding a very significant disease. And pain is a good indicator of something to tell you that something is wrong. And if we treat it completely, then that makes it hard to follow something new come up that has to be aggressively treated. So let me know if I'm talking too fast, or if I'm not making sense, or nervous, or slurring my speech, or anything that makes this less than optimal presentation. So this is a case where it's a 61-year-old man He had a history of AFib, and he's been on Coumadin for a while. For a while means more than 5 years. He came in because he's got this left thigh pain proximal to his knee after he fell, tripping on his rollator at home. He did not lose any consciousness. 2 weeks ago, he had a left knee plica release. It's something to stabilize the knee because he has unstable left knee. What's complicating is he had a history of stroke and he's got a left foot drop. So he wear an ankle foot orthosis, and that if he doesn't wear it, that makes his knee very hyperextensible. So it's like a bowl kind of thing. So orthopedic was involved in that case, and he did surgery, and then during the follow-up, they found a hemarthrosis in the left knee, and that was evacuated a few days later. So that's less than 2 weeks, so that's about 10 days ago. So on arrival, he's got the left knee and pain and the swelling. So what's the first thing we do? We do the X-rays, and we do ultrasound, B-modes, bimodal duplex to see if there's any DVT. Lo and behold, he had a superficial vein, femoral vein, DVT, and recurrent hemarthrosis. So this guy is on Coumadin. He had surgery 2 weeks ago. He's at risk for DVT, which he has the DVT. And plus he's got the bleeding into the joint of the left knee. So he's got the bleeding and the clot going on at the same time at this point. So it's a conundrum on what to do from this point on. So we'll tell you what we do. We got our first guy who is there, who's an orthopedic that's on right there that we can talk to. We consulted him because we kind of thought that it was an emergent thing that we need to do. We call him in, told him that this is a situation. He was not very impressed with the hemarthrosis, so he said, continue Lovenox. So we agreed with that. And then subsequently, I had a nagging suspicion. So I also called the orthopedic guy that did the surgery 2 weeks ago, which did the evacuation of the blood from the joint. And he actually came in. He still had the stitches, so he took out stitches and he took a look at it. He was not concerned about the hemarthrosis also. And neither of those guys are concerned about the left thigh pain, which all of us contributed to the DVT he has, which is right there. Plus he's got Baker's cyst on behind the left knee as well on the ultrasound. So this is a situation. As anybody at this point will do anything different? Let's start with you. It's okay, you got to start somewhere. There's no wrong answer. So do you have any questions on the situation so far?
No.
The conundrum that we're in. Did I go too fast?
No.
So can you summarize what I said so far?
So he had surgery for stabilization 2 weeks ago, presented 2 weeks after with DVT and left thigh pain, DVT. Ortho was reconsulted again. They didn't have any concern for the hemarthrosis or the thigh pain. I don't know what you did for the DVT though.
He was on Coumadin. You want to know what the INR was?
What was that?
It's 2.0.
They told you to continue the worker?
No, we switched it to Lovenox. Yes,
Okay.
weight-based Lovenox. So the therapeutic
Okay.
dose, Lovenox.
Even though you had the
Hemarthrosis.
and the hematoma.
Oh, we don't know about the hematoma yet.
Oh, you don't know about the hematoma yet?
No.
Oh.
That's what's lying underneath all of that. Debbie gave it away so fast. Come on.
No, I don't remember you saying.
So we have hemarthrosis, not hematoma. We don't know about the hematoma
Oh,
yet.
hemarthrosis. Oh, but
And the left knee.
you said hematoma.
Oh, 2 weeks.
Early slide. Oh, 2
So
weeks.
we haven't got there yet.
So he was on Coumadin for the AFib.
Yes.
And he was then continued on the Coumadin because
He probably was
needed
interrupted
prophylaxis.
during the surgery.
Right.
He was probably interrupted for a few days.
Right. But
And
then he
then-
was continued on his previous therapeutic dose, and it was
Right.
initially thought that was going to be treating his DVT as well, right?
Well, we don't know about the DVT. It was a new founding during the hospital stay. I mean,
Oh, okay.
during the admission.
Okay,
So DVT is completely new.
okay,
That he didn't have DVT 2 weeks ago,
that we knew of,
that we know of.
yeah.
Could you describe the ultrasound finding a little bit more?
Us-
Is it superficial
Superficial femoral vein is considered a DVT.
in size?
Size was quite extensive, but not totally occlusive. So probably about 4 to 5 inches of the vessel was included.
I have a question, like, it looks like you got the CT on day 3,
Okay, so
like,
now
why,
everybody has read this. I should have put it on the next.
Admission at 2, right?
why,
So,
why
INR
wasn't
was
the CT
two.
done, like, right away?
What's your
Like,
question,
why
Jessica?
wasn't the CT done, like, right when he walked in, if he's coming in with 5
Because
days?
we did not, what would be the indication for the CT?
Well, he had like,
We did the X-rays, and we already, with the X-rays, we found the hemarthrosis, and we got a DVT. So with those two, we have explanation for why he has the left thigh pain, or so we thought. That's why I asked you,
But if
without the
you're-
CT, what would you have done
if you're
differently?
suspicious for like, compartment syndrome, I probably
We,
would have.
we
done-
never suspected that.
So at this point, they're not suspecting compartment syndrome. They got the DVT because of the unresolved
Because,
pain.
what is a symptom of a DVT? You got redness, swelling, and pain, right? That explains everything that we found on the exam. And plus, what?
CT is not going to tell you.
I don't know.
And,
That's on physical findings.
Right, and also the Coumadin was not super therapeutic, right?
Mhm.
If the Coumadin was 5 or 7, yeah, of
Sure,
course we would
yeah.
do something different. So that's why I'm asking everybody here, what would you have done at this point? And then yes, 3 days later, the pain was not getting better, so the orthopedic guy ordered the CT of the left leg and found out a huge hematoma in
So,
one of the.
was there concern for an active bleed? Like, wouldn't you do
Yeah.
vascular studies to determine if
No,
whatever
that's-
caused the hematoma?
And even with the CT finding, they did not think it was an active bleed.
Okay.
Did he have like a drop in H&H at all, like initially?
Right. Oh, we're gonna go there. Good.
Cause I
You're
mean,
gonna-
if there's a drop, then I would be like,
So
oh
you're
my
gonna-
God, they're
you're gonna-
driving
yes.
through, yeah.
So, yes, the same concern that we had with the hemarthrosis was that if there is significant active bleeding, then he's gonna have drop in H&H.
Yeah.
It did not.
What pain medicine was he
Sure.
on?
He is on quite a bunch. He's on Norco and Tramadol. That was not touching it. We put him on fentanyl patch. That was not touching it. And then eventually we put him on morphine, scheduled morphine with the breakthrough pain, PRN morphine. So that controlled the pain, barely enough for him to sleep.
Can I take you back and ask
What?
one more question?
Sure.
One funny bit. When you're waiting for day 3 and you've been
It's
through
the
all
pain.
the level of pain med,
Mm-hmm.
are you not questioning at that point, this is some pretty high pain med for this issue?
Yes, we do. But the other thing is that he's got dementia. So our attending at that point has a philosophy that if you have dementia and if you forget about the pain. And usually people with dementia, he said, will have exaggerated amount of pain.
What was your pain AD score?
Pain what?
Pain AD scores.
He will be right up there, like
Yeah.
8 or 9. He's screaming. He cannot toe touch on
So
the
that's
left
all you
knee.
need, yeah.
Cause that seems a little funny.
What?
Especially if he's like really connected touch, that seems kind of funny, like it doesn't seem like it would be like a DVT at that point.
That's why we were aggressive.
Yeah.
So we, honestly speaking, the hematoma never was in our mind because we already have hemarthrosis. So that's why I say something obvious that we already found is really blinding us about what else could be wrong. And also the fact that he's got dementia, and with people with dementia, it's very hard for us to know whether or not their pain threshold, what their history is. The other thing is, until that point, we had a hard time getting in touch with his son, who works night shift, so he's sleeping during the day. So he's a police officer, and we cannot get in touch with him for 3 days. So that was another thing that was complicating this
Like,
case.
on your exam, was it changed in color? Like at all the skin?
It's erythematous, but no other
purple
changes.
or-
No purpling.
Yeah.
That was the exam I'm gonna go is that on the exam he had no neurovascular compromise. So he's got good distal pulses, good sensation distally. So there was no neuropathic sequelae of the compartment syndrome that is probably happening. Also, let's talk about compartment syndrome. Compartment syndrome happens only in a very tight places where there is a lot of very tiny fascia enclosed area. Usually compartment syndrome doesn't happen in a big area where the thigh quadricep muscles are. So that also put us at a lower risk.
Did that happen anywhere?
So usually it happens below the knee, compartment
Oh,
syndromes.
okay.
Below the knee and also in the elbows and other areas. So we did not suspect that at all. So, as we were saying, the timing of the stop I could have done better. But anyway, the Coumadin was stopped and the Lovenox was initiated because we were thinking that Lovenox can be stopped pretty quickly if we have to, if we start bleeding. And then, as we say, pain was very disproportionate to his physical exam and neurological and everything else findings that we had in tier 1 to 3. And he's got dementia. We did a MOCA, even with his pain going on. He had a MOCA of 18. He had a history of hemorrhagic stroke 20 years ago that with seizure history that makes his history very unreliable. It's hard to get most of his history from him. And then we did escalate the non-caloric doses. And then on day 3, we stopped the Lovenox order because of a new hematoma finding. All right, that is very aggressive because at that point we don't have the IVC filter in yet. And IVC filter was put in the day after we stopped the Lovenox. That's because the pain was not controlled at all, even with the high dose of morphine that we're giving into him. And as the new finding shows no neurovascular compromise. And then right after we stopped the Lovenox, pain elevation was almost instantaneous. So one day after that, it dropped down to like 5 or 6. And then on day 2, after stopping Lovenox, it was 2, 3, or 4. And it was pretty rapid and gradual. So lab findings, Jessica was saying, do we follow H&H? Yes, we did. I thought that was enough. So if there's no change in H&H, we would not be thinking about active bleeding. So we couldn't explain why this guy had so much pain. I mean, I call it compartment syndrome, but I mean, to diagnose it concretely, we need to have invasive compartment pressure measurements. So this is my far-fetched kind of like a clinical symptoms only diagnosis of compartment syndrome because of the disproportionate, based on the clinical finding of disproportional pain to the physical finding. That's my only diagnosis that we can come up with. Renal function was good, and INR, initial INR was 2.0, and within 2 days it dropped down to normal. And on physical findings, he's got the left lower extremity slightly firm, so it was not drawn tight like compartment syndrome. So there was a lot of guarding and a lot of pain. He could not go touch on the left foot at all because of the pain. Physical therapy cannot do anything. He's got reduced flexion only to like this much, so about 30, 40 degrees flexion only. And on palpation, there was a small to moderate effusion of the left knee. That never changed in size throughout this hospital stay. And then there was a weakness in the leg elevation and knee extension, about 3+ to 4 only, because of the pain. So that was the only kind of positive neurological finding. It's hard to differentiate whether or not it's guarding secondary to pain versus the real nerve compression syndrome and the compartment syndrome that we're going to see. So what could have gone wrong? We could have had the permanent nerve damage or muscle damage, rhabdomyolysis from this compartment syndrome, myopathy and weakness, neuropathy, pain, and with causing delirium from the pain or from the medication that we used to treat pain. He could have been fallen with more injuries. He did not get that. and deconditioning with complete osseous independence. He did have deconditioning and he has residual weakness weeks later. So I follow up on his case, and orthopedic show that notes show that he has residual weakness even with the rehab therapy. So that might be the residual morbidity that as a result of the hematoma, the size of the hematoma. So hematoma, what could have gone wrong with hematoma? He could have increased hematosis and increased hematoma and infection of either of those two. There's some possibilities. And then also we did not put it on there, but there was also inflammation-related leukocytosis without any significant fever and cultures, or all negative. So if we were not very careful with that, or your hospitalist or just a general internist, we could have treated him with antibiotics without really needing to and cause ulcerative colitis. Those are all the pitfalls that are possible that thankfully he did not have. So at this point, anybody has any questions on what has transpired for this guy? So right now, before you start, is hospital's day was he came in on the 7th and he was discharged on the 15th. So that was a stay of about 8 days. Of course, the last 3 days was because of insurance issues. So insurance was not approving transfer to a rehab facility. So he's lay in bed. He was happy. It was the last 3 days. No problems at all. No pain medication. 2 or 3 days. 3 days after stopping Lovenox, he had required 0 pain medication. So that's how significant the effect of the hematoma was. If anybody has any questions, what else could have gone wrong if we didn't catch it early, or if we did something different? This is only a very relatively young 69-year-old. Albeit he's got dementia, that's probably early onset. So what would you do differently? What would you, if you have hindsight 2020, what would you have done differently? Jessica?
I would have gotten the CT scan.
You would have gotten a CT scan earlier?
Yeah.
On what day?
Well,
So if you say earlier, so what day would you start?
when he came
already?
in.
When he came in?
I think the physical exam was a little weird. I don't know. I think that would trigger me to think maybe something else that might be going on tonight's just a DVT. Just with the amount of pain that he was in, it was kind of disproportionate.
Okay, so yes, you did CT scan, so you see a hematoma, and you know that you have a DVT. What would you do to treat it?
Well, I mean,
Now you have 2 things going on, 3 things going on. You've got hemarthrosis, you got hematoma, he's screaming in pain. We don't know whether the screaming is either from a DVT or from a hematoma, because they are all in the same location. So what would you do to treat him? Would you anticoagulate him?
I mean,
do
you have to treat the
surgery?
life-threatening thing
What
first,
would
so
you
you
do?
would have to focus on the compartment syndrome, because if you don't, he's going to lose his leg,
Mhm.
or if you kill him.
So what would you tell the orthopedic guy? So you're there, you're attending of the case. And this guy is screaming in pain. He's got dementia. We cannot touch base with his family because he's not accessible. And we deem that he likely do not have capacity to make medical condition like give consent. That was another problem that we had, is to get consent. So what would you do? So you say you have maybe a compartment syndrome?
Well,
What
that's
would
an
you do in that
emergent
situation?
I don't know. I mean, you would have to get someone to consent, but maybe since it's an emergency, then you would have to treat.
What's the treatment?
A compartment syndrome?
No, I mean, in general. I mean, this guy is now, you have hematoma, hematorosis,
I mean,
and a DVT.
With the compartment.
What would be your series of steps? What would be the first thing you do? What would be the second thing, third thing, fourth thing?
Call surgery. A bad compartment syndrome.
Okay.
That's an emergent surgery right there.
Okay.
To relieve the pressure.
Christina, I know you're itching to say something. What would you do?
I didn't think this isn't compartment syndrome, though, is it?
You have to
We're not thinking, no, we cannot diagnose that without measurements, no. So what would you do if you did what Jessica suggested you do and get a CT scan on admission with an INR of 2 and you got a DVT and hematosis, which we had it before. So it's a recurrent hematosis, that's not a new thing. So what would you do?
And then you have to weigh the risks and benefits of what's going to cause more damage, the DVT or the hemarthrosis. And so,
So what would you think is more risky at this point?
at this point,
Wait, at this point you have to know that we haven't treated him optimally with pain medication yet, right?
Right.
Because she said it's on
I
a
mean,
mission.
if the H&H is stable and
Mhm.
what imaging you've done so far.
Yeah, initially his H&H was 12.
And I mean, if you
And
do
36.
serial measurements and it's not dropping,
It's not dropping for the first 2 days.
there's no evidence that this is active bleeding,
Right.
I would almost err on the side of anticoagulation.
Right.
But I would watch him very closely for drops in H&H,
Right.
progression of the hematoma. And then if there's anything to suggest that it is getting worse, then I would stop anticoagulation.
What is your threshold to order compartment pressure measurements?
I mean, pale, pulseless, the pain that's kind of off the charts.
Right. So the only thing that he had was pain was off the chart. That will suggest compartment syndrome at this point. There was no paleness, pulses were excellent. There's no neurological compromise dystally on the left leg. So that's what we did. And only on day 2, late in the evening on Thursday, then I was able to get in touch with the son and get a quick consent to do an IBC filter. And that's exactly when I stopped the Lovenox preemptively before we do the IBC. So, and consent, we were thinking that we could have even gotten, like Jessica said, emergently from the patient himself because it was emergent. So.
Well, with the dementia, I mean, is that even going to be valid? At what point do you have to intercede and get a guardianship if you couldn't gotten hold of the son?
If there is a risk of loss of life for them, then we could proceed without any consent, yes.
They can actually get consent by higher level physicians, like in the hospital in
Right,
an emergency.
Well, in an
Like the chief of medicine.
Yeah, the chief can
That's what
open
you
up
would.
if it's urgent.
Well, even in an ICU setting, if you need something like a PICC line or something, like something emergent, like a line of sorts, you can just double dock it, have 2 physicians sign the consent. So,
Yeah, well, so you were trying to get the father, right? I mean, I'm sorry, the son.
The son, yes, who works night shift. So I caught him before he went to work.
Okay.
So he was sleeping for the most part. He never answered his phone.
And this patient was full code?
Yeah, he was full code,
Okay.
totally full code. His dementia was not documented before, so it's
Yeah.
something new that we found out.
So
So he's not on any
dementia you guys
medications.
diagnosed during this hospitalization?
The dementia,
With
yes.
the motor?
Yes.
So you didn't know like his ADLs from before or?
He was in independent assisted living
I mean,
before.
hindsight is 20/20, you know, but I probably would have still gotten the IBC filter right away, you know, without, like, double docket.
Without waiting,
Yeah, double docket, like, I would have just done that.
Right.
Without trying to get a hold of the son, because who knows when you were gonna get a hold of the son. And if
Right.
he's full code, that tells me that they want everything done, you know.
Right.
So it's when they're DNR, DNI is when you question, but even that's a reversible quote-unquote condition, that's an easy fix.
Okay.
What if the bleeding, what if the bleeding had been worse? Like, I think we got a little bit lucky in this case, in that, like, he didn't lose his limb. Like, what if it would have been a real bad compartment syndrome, and you would have given him anticoagulation for 3 days?
Right, that's all.
That would have
That's,
been really bad.
that's why we're doing MNF.
Well, he was on anticoagulation, right, the whole time? He was on
Yeah.
Lovenox.
So she said
Yeah,
that if by the virtue of us giving him anticoagulants in the first 2 days, what if he did have severe compartment syndrome?
Continue.
And
It would have made it worse. He would
the
have
thing
had
is
to-
that
Oh, yeah.
well, I'm hoping that our clinical skills are good enough to catch the vascular compromise
Yeah.
and the severity of the pain before something permanent happened. So we were following him closely, and the only positive findings of compartment syndrome that we had, with the lack of compartment pressure measurements, was the disproportionate pain that we had. And until the CT scan was done,
Yeah.
we did not know whether or not his hematoma was getting, even there or not to even talk about whether or not it's increasing in size. So we had no way of knowing.
Everything you do in medicine has a risk. I mean, something like a paracentesis, you do it because you want to relieve some of that pressure, but you can end up causing a bleed. You can end up throwing somebody into Palliative syndrome. So, I mean, just being cognizant of the things to look out for.
Right.
And it sounds like y'all were, so.
Yep. But like Jessica said, it could have gone south a lot worse. Or, as Debbie said, if there was a gap between stopping the anticoagulation, even though the lower nostril takes about 10 to 12 hours to get out of the system, which was within that time after that he got the IVC filter put in. So,
Was that something you were thinking about as you were going?
yes, we were thinking about IVC filter from the get-go that we were going to do.
But I mean, on the
if-
time frame, was that in your head for the low NOx levels?
What do you mean by time frame?
Well, you're saying, it takes 12 hours or more to leave the system.
Yes,
You know that
yes.
you're still having
Yes,
some effect.
so we took a calculated risk.
Okay.
Yes. Yeah. Because he was so much pain, and at that point we were worried about the compartment syndrome right after we found a hematoma. So what we didn't do too well was we should have been more concerned about the disproportionate pain sooner and treat it or find out aggressively what's causing that. Also to measure, it's not scientific too much, but to measure the size of the left thigh, where the problem was, and whether or not it's increasing in size. So that might be a little bit more sensitive than following H&H at that point. And also, the other thing that I found across in the reading literature was you may be using the degree of flexion of the left knee as an indicator of how big the problem of the hematoma was. That's another thing that we could have done better. And also that to realize that bleeding and thrombosis could always coexist together. And not just in one place, but in more than one places. But in this case, it was in two places, in the joint and in the thigh also. And early insertion of IVC filter, as Debbie mentioned, even without consent and double dogged, we could have done it sooner rather than later, and not risk thrombosis into the brain or the lungs. And also maybe closer communication all around, not only with the orthopedic doctor, but with the family members to get consent sooner. Evidence-based practice, good. So what I found, some gist that I got from literature research was that making a diagnosis of compartment syndrome is extremely hard clinically. It needs the intracompartmental pressure, which most orthopedic guys or surgeons are very reluctant to do because depending on the device that they use, there could be a lot of intrinsic inaccuracies involved with that. There was no gold standard for which test is better than other. And also that, temporary suspension of coagulation for primary prevention of a stroke from an infant, it's okay if you are suspecting the bleeding risk is higher than the thrombosis risk. And also the other solid piece of information was that when they're doing the compartment pressure, the difference between the diastolic pressure and intercompartmental pressure, if it's less than 30, then that is a solid indicator that he's got compartment syndrome. So, to put it another way, the closer the pressure differential between the diastolic and the intercompartmental pressure is, less blood flow is there going to be distally. Because then if you have to go through, it's like a traffic. You know, if diastolic pressure is over the pushing pressure, and if that pressure is not much bigger than what exists in the compartment, then there's no blood flow distally. So that's essentially what it's trying to say. They put a number to that. So I was not too aware of that number, so it's a number that I want you to take away in case you have to do a discussion with orthopedics down the road. It's very rare, so, but still, it's something you want to keep in mind. And also, there's also mentioned in the literature that the morbidity, even if we did everything right, if we did everything right and we are godlike in our diagnosis skills, and we did the intercompartmental pressure measurements and we do fasciotomy like we should, even with that, fasciotomy carries with it a lot of risk. A lot of necrosis and infection risk and everything. It's not a benign treatment option. So even if we are very aggressive, you know, as Jessica said, oh yeah, this is the compartment syndrome, acute compartment syndrome. Let's call surgery in. Let's do everything we can. Let's do it. And even with that, there's a lot of risk with that. So everything has to be balanced. So persistent weakness is one of the most common residual symptom, and this guy has that, even without the fasciitis. Knowledge gaps, you know, these are things that we already went over. Bleeding could be anywhere. Anticoagulation, we have to weigh risks and benefits very, very closely, and even if we know everything, balancing is a delicate art, and always measure subjective physical findings if you're unsure about what's going on, like by my measurements and like serially measuring how much flexion he has and things like that. All right, that's pretty much it. Take home points. Always watch out for potential atypical presentations of diseases. Always collect as much collateral information as we can. Also, my take-home point is don't be afraid of talking with a lot of the specialists. Always get to know them, make friends with them, learn from them. So the older the specialist is, the more experience they have to share. So, you know, don't be hesitant to approach even the most grumpy orthopedic surgeons and learn from them. And be decisive when things are not going well, like stopping the coagulation or putting in an adhesive filter. You have to be decisive. It's nothing worse than being indecisive and not doing anything. Sometimes not doing anything could be as dangerous as doing everything. So there's always a middle road. All right, and also even with people with dementia, another take-home point is always believe them. Always take the benefit of doubt and believe them first. If they say they're in pain, yes, they are in pain. They're not making it up. Doesn't matter what the attendings say about dementia and pain thresholds and all that. Always think that they have pain. All right, that's it. Any questions?
The one patient I ever had with compartment syndrome presented with severe out of proportion pain that we could not explain. Pulses were still intact.
Yeah.
But that's what it was.
Did he get fasciotomy?
Yeah. Yeah, not really.
How long did it
Not
take?
prompt though.
Not prompt?
Not as prompt as it should have been.
Yeah, right. That's always
Yeah,
the case. That's
yeah.
the problem, is because
Yeah.
they never present in the classic textbook picture.
Yeah.
I've had those in the past too. The compartment syndromes. It's scary.
Never forget. Yeah.
Do you see how large the hematoma was actually on the CT?
The size. It's almost throughout his small little muscles that he has, almost spitting out the whole.
Yeah.
But it's got in a fiery, like, you can get even.
It could get huge before it
Huge.
cuts off any
I've
circulation.
had
yeah.
cases where it was the thigh and hip, but it was almost like a soccer ball size.
Mhm.
But patient had a lot of pain, but it never led into compartment syndrome.
Mhm.
Was his leg really hard?
No, that's the thing. If it was hard, it's a no-brainer. The hard cases are where none of the symptoms are classic. You know, I mean, it would be so easy if everything you learn in the textbooks is what you see in the practice. It is never a textbook case. That's why medicine is still an art. But we enjoy doing it. Right?
So this happened in August, is
No.
that correct?
October.
October, okay, so at this point, there's no plan to get him restarted on anticoagulation?
Yes, there is.
There is?
Oh, good
Or
follow-up
is
question.
AFib?
Yes. He was off coagulation for 4 weeks and he restarted after.
How about getting the filter out? Any thoughts on that?
I don't know if I've known anybody who took in their IVC filter out. Once you put it in, you don't.
I mean,
You're
in theory,
No, you're
they're
supposed to.
removable,
The
but you know, they often don't
recommendations-
get removed.
No.
The recommendations at this point are to remove them after the acute whatever's over.
So
Right.
usually 6-9 months or something like that, that they recommend that you take them out.
But yeah, it never happens.
It never happened. Well, have you ever seen one that got taken
I've
out?
seen a few,
Very rare.
but I've also made my head
Personally-
small about the others.
Usually those are the case of young people, I would think. If there's not very long life expectancy and the trauma are getting it back out, usually it's like an arrow, right? It's easy to go in with an arrow than to come in, take it out. It's go reverse, and it's hard taking things out of your body than to put it in. So in this guy's case, we don't know whether or not he's going to have another DVT or another bleeding episodes. So we might as well put it in and leave it there, because if he has another DVT and another bleeding like he has, then we have to put in another IVC filter. So I don't know, somebody smarter than me would know, what are the risks of having an IVC filter?
I mean, I think your risk of
Forever.
distal clots is actually, if anything, greater.
Greater, yeah.
Yeah. So,
Just like in
Like,
Chinese.
yeah,
Oh,
anything
yeah, before that,
downstream.
right,
you know.
downstream, yes.
Yeah, so. But,
Pneumonitis for bigger clots.
Exactly.
yeah,
Pulmonary
It's a
vascular.
foreign object in your body.
Mhm.
so, yeah.
Interesting.
It's really a good.
Very good. Oh, you want something?
Okay, make sure you sign it in and complete the evaluation. I'll give you your remarks by the today.
Yes.
And then ask them. Okay, do my elbows Thank you very much.
Christine, are you gonna come to the party
Party
on Friday, next Friday?
for the what? Do you want to go down like the
Run to the bathroom.
down like the Titanic?
You're good. I'm gonna run to the bathroom.